Hello, everyone, and welcome to today's session. Thank you for joining us. It looks like we have attendees joining us in this moment, so I'm just going to pause for about 10 seconds to allow more people to enter into the webinar room. Thank you so much for joining us, to everyone who has entered the room thus far. All right, great. Well, thank you again for joining us this morning or this afternoon, depending on where you are joining us from, and welcome to today's webinar. This 30-minute webinar entitled Response to a Suicide Cluster in One Tribal Community is featuring Dr. Marilyn Zimmerman. My name is Shannon Shipman, and my role today is to ensure that we have a technically sound webinar experience. That said, if you experience any troubles throughout the session, please send me a message in the chat box, and I will help you from there. We also encourage you to utilize the Q&A box located on your bottom menu bar. We'll leave time towards the end of the webinar to answer all of your questions, or as many that we can get to. And that's all for me, but I am going to turn things over to our moderator, Chanel Ford.
Thank you so much, Shannon. I'm Chanel Ford. I will be the moderator for today. I am a member of the Spokane Tribe of Indians. I work for Kauffman Associates. Last week, you might have been able to participate in another wonderful facilitated webinar. We at Kauffman Associates are celebrating 30 years of doing work that matters, and we really wanted to kick that off by showcasing some of the work that's been done in Indian country, specifically geared towards suicide prevention, health, and wellness. So to continue that effort and to continue having this discussion, it is my honor to introduce you all to our next presenter, Dr. Marilyn Zimmerman. Dr. Marilyn Zimmerman provides expertise in trauma-informed systems change and systems serving American Indian and Alaska Native children and families as Director of Policy and Programs for the National Native Children's Trauma Center at the University of Montana. This presentation will discuss the effective strategies utilized to support tribal children and youth in their school, families, and community after a suicide cluster of middle school students. So without further ado, I would like to present Marilyn Zimmerman. I hand it off to you, Marilyn.
Thanks, Chanel. I appreciate it. As Chanel said, my name is Marilyn Zimmerman. I'm an enrolled member of the Nakota and Dakota Nations, also known as the Fort Peck, Assiniboine, and Sioux tribes. We reside in the northeast corner of Montana. I'm a descendant, an Ojibwe and Nawa descendant, and a little French and a little Irish also. So I just want to do an introduction to one community story and give you some very broad brush strokes and some of the highlights of what worked and what didn't work. What we tried, what we thought was going to be brilliant and kind of fell apart, and what some of the reasons why it kind of fell apart. Some of the surprising things that worked that were very low cost but high impact. And so let's just get started. So there is a tribal community that we work with who experienced a suicide cluster of 5 middle school students in about a 4-month period of a school year. And it just devastated the school district, it devastated the community, it devastated the entire reservation. And they reached out to us to start having conversations about what it is that we can do, and what kind of supports we could provide for them. We had done a lot of work and were trained as applied suicide intervention skills training providers. Some of us were master trainers, so we could provide things like gatekeeper trainings in assist. But we found that because there were some of us on our team that were from that community, we also understood some of the barriers to some of the work that could be done. And so we tried, the whole idea was to just try to build collaboration and embed it in a school response initially. And then we added something, the World Health Organization's brief intervention in contact with suicide attempters model. And we'll talk very briefly about that. And I'll give you the citation for it so you can find that on your own. So what did we need to do? We really needed to reduce stigma. We were finding out that people were talking about having attempted suicide several times before they came to the attention of a loved one or a provider. And so we started to think about what would that look like? How do we do that? And we had started out asking the tribal elders, how do you feel about, or how do we, as Nakota and Dakota people, how do we understand suicide? And how do we talk about it? How do we talk about it in ways that doesn't create fear? How do we talk in ways that provide support? And so they provided us with just the notion that we, our whole culture is about life, about well-being, about sustaining life, and that we didn't want to do anything that would create any sort of weight on or shame towards family members who'd lost those to suicide. So that's where we really started having that conversation. And then being able to train people with gatekeeper trainings to really help them understand suicide within a broader context. And for many people, they were very terrified that they didn't know what to do. And so the gatekeeper trainings was an attempt to try to support them in understanding that they could play a role in supporting their child, their adolescent, their spouse, their friend, who are having suicidal thoughts. So the big idea was then also to place some of the assessments around suicidality in a primary care setting. So that was, I think we call that integrated care now, but way back 10 years ago, we just said in a primary care setting. So in a place where we could do evidence-based assessments for suicide risk, and then also do brief assessments and brief interventions around their trauma histories and their substance use and abuse. And Indian Health Service has a brief intervention that they use for substance use. It's a harm reduction model, and it seems to work really well in reducing repeat visits to the emergency room because while you're under the influence, you're either in a car wreck or a fight, or you fall, or something happens that you injure yourself. So those were the sort of goals initially. So we attempted to adapt the World Health Organization's ED response. And here's the citation. Effectiveness of brief intervention and contact for suicide attempters, a randomized controlled trial in 5 countries, and it's Fleshman et al., and it's in the bulletin of the World Health Organization. And so a big part of our response and trying to get people to reach out for help, either for themselves or their loved ones, and first thing was to take all comments about suicide by their loved ones, by their relatives, seriously, and not get them supports or help. Be able to respond by taking them to the emergency room, or taking them to the clinic, or taking them to the city clinic, whatever that looked like. But the big piece is that we also looked at the research, and we found out too that emergency room staff often don't respond well to those people who have come in with a suicide attempt. They have beliefs about suicide. They have attitudes about what kind of people attempt suicide. And so a big piece of the conversation was going to be about helping them understand suicidal ideation and people who are having thoughts of suicide. And then having that brief intervention and contact, being able to, assess them and get them help and supports immediately from the emergency room. We had a hospitalist who was a champion. We hired a clinician, and we also hired a case manager that were right in the community. So that was the big idea for one part of the project, was that there would be this response, because the World Health Organization found that the highest risk for completing suicide is a previous attempt. And so they decided that, well, if we're seeing these people in an emergency room, what's happening after they leave the emergency room? Why do they die after that contact? And so they, in 5 countries, not all of them developed, they created this model where they hired a local person, didn't have to be well-educated, just had to be a local person that cared. And they trained them in this model, and they would make contact at prescribed intervals, like every, 2 weeks out, 3 months out, 6 months out, 9 months out. And they would just make contact and ask how they were doing, what sort of supports did they need, was there anything that they could, provide for the person who had attempted suicide or their family. And it greatly reduced the completed suicides in all of those countries. So that was the big hope, because we know in Indian country and rural America that very often we don't have the PhD level folk who, or even master's level folk. We need to use our local natural helpers. And I'm seeing that I'm have to rush through. So lesson learned, suicide prevention has to engage all the systems. It can't, we learned that everyone was looking to the school to do a response, or they were looking to tribal health. And we have to understand that it's a complete community response to suicide prevention. Again, making sure that we understand the cultural norms, including the taboos about suicide, and really seeking the guidance from those traditional spiritual leaders. Again, respecting tribal sovereignty. So any data collected, the tribe owned it. It was overt. It was within the context of an MOU. It was stated in the MOU. And then ensuring that our service provision, training, and outreach to policy leaders doesn't further pathologize groups of people or reinforce unhelpful stereotypes. So really finding a way to talk very respectfully and thoughtfully about the high rates of suicide in Indian country in general. Building an interdisciplinary capacity for suicide prevention is really relevant. You have to have everybody on board and have to have all their perspectives, willingness to collaborate with one another, and be willing to engage with tribal leadership. So collaboration is a huge piece of the conversation. And the tribal health director in this particular community was the champion for collaboration. And he developed a tribal resolution for us to come in and do work alongside he and his department. An MOU was created with all of these providers that you see listed. So everyone was participating in at the time of the most urgent time, once a week. There was still some need for county health and mental health and Head Start folks to join in that collaboration, but everybody was really on board. A big piece of the conversation is really in suicide prevention is building that resiliency. So that outreach from the emergency room was meant to help support and build resiliency, not just in the person who had attempted suicide, but in his support system, in his parents or his spouse or his children, whatever that looked like. That was the big focus too, is looking at the resiliency of us as a people and us as individuals and families and communities. So building resilience is really about ease of access to a variety of clinical interventions and support for help seeking, strong connections to family and community, developing problem solving and conflict resolution and nonviolent handling of disputes. Because very often we found, and we know that this is a protective factor, but we also found during our work there that many of the suicide attempts occurred after a conflict, not necessarily a violent conflict, but after a conflict with somebody, a loved one. What are cultural and religious beliefs that discourage suicide and support resilience? Safe, supportive school environments, that sort of thing. You guys can read that. So resilience is really a positive, adaptive response in the face of significant adversity. And it naturally exists in all of us, but it can be built in all of us, but reminding ourselves that it also can erode. So positive responses to adversity happen in the context of supportive relationships and community resources. We like to say that the best trauma intervention, evidence-based trauma intervention that exists is a loving, nurturing relationship. It's one of those relationships then that, the support is unconditional, the person shows stability, and the child actually is the one that trusts it, not an adult caregiver saying, oh, you should trust this adult. So that leads us, when we knew that, also our immediate response was to go into the school district that experienced the loss, help them do some grief support, sports around grief and loss with them, do some training in assist QPR, and brought in Native Hope with Dr. Small, Clayton Small, and looked at community outreach and what that could look like. But one of the most significant things, and it's already 19 minutes in, that I really want you guys to know that was the most impactful to me as a person on the outside, was this idea that we reached with the school, where we went in and we did an assessment of, they identified, the counseling staff identified the children that were most at risk for attempting suicide because of either their locational relationship or their friendship relationship or relative relationship to the children that had died. So I think there was probably about 30 kids of various ages from grades, 5 to senior in high school. And so we did a debrief with them as a group. And then we decided that we would create what we called a self-care plan, which was really sitting with them individually to help them develop a safety plan, right? So we started asking them questions like, what helps you feel better? What makes a difference in your life? Who makes a difference in your life? And they told us that. And then of course, we let them know about the all of the emergency, like Lifeline, crisis text line, 911, all of the places where they could reach out to for help if it was the middle of the night and they couldn't get a hold of anybody, right? That sort of thing. But then we went a step further as we developed that self-care or that safety plan with them. We said, please identify somebody in this school district, an adult, who you feel cares about kids, cares about you, and cares about the well-being of all the kids in the community. And so each of the students selected one junior high 7th grade girl selected the high school girls basketball coach. One 10th grader selected his 7th grade English teacher. So it wasn't that they did their homeroom teachers, they selected them. And then we went to those school staff and said, Jane Doe and John Smith have selected you. They think that you're someone who likes them, likes kids, cares about them, as someone to reach out to. And so we're going to ask you in this next semester to twice to meet with the students, go over their self-care plan or their safety plan, ask them how they're doing, and just make that brief connection. Well, we had to get parental permissions. And so one interesting outcome was there was a group, unfortunately, most of the students that died, 4 of the 5 were girls. And it was like 5th and 6th grade girls. And of that group of girls and their peers, those that were given parental permission to participate in this self-care plan idea, all of their school discipline referrals went to 0, and all of the girls in this particular group that weren't given permission, their discipline referrals went up. So we're going to have lots of responding. So it really was about having a caring adult that they could look to, that they knew that they could reach out to, and having those mentors just check in with them 2 times in the semester. Unbelievable changes in the kids that got to do it. Of course, we provided cognitive behavioral interventions for trauma in schools, which is a group around addressing trauma symptoms, and grief and loss is one of the biggest indicators of trauma in American Indian children. Thinking about school-wide interventions after school and summer programs, and the need for community safe houses that came much later. In fact, I think they finally have one. Created an emergency shelter this last year. So when we strengthen youth resilience and reduce suicidal ideations, programs are well served when they take in the consideration of the whole child. So quickly, because I want to get to questions, here's some of the successes. We did increase help-seeking behaviors. Lots of people were taking those threats by their relatives seriously. We did reduce stigma. We were able to talk about it publicly. We were able to talk about it privately. And people were willing to talk about it. Increased number of community members that participated in the gatekeeper trainings. We did many over the years. Increase the number of patients receiving clinical services. So they created a referral system from the emergency department that was not a tribal hospital's emergency department. It was a community hospital to the Indian Health Service. They developed a hospital safe room. So the challenge is they developed a tribal code that criminalized suicide behavior that just got taken off the books this year. Because they said, well, you know, my relative says, and I said, well, we should take you to the emergency room, and he won't go. So they're starting to call 911. And the tribe didn't know how else to respond other than to make it illegal. And then they would spend time in jail, which increases risk for suicide in adolescents. So it wasn't helpful. That was very challenging. Underutilizing of the safe room. Patient transportation is always huge. The nearest hospital was 250 miles away. And there was no one knew who was supposed to be responsible for getting them to the hospital. And in conclusion, wow, youth suicide is a community problem. We have to do it as a community. All of our responses should reflect that. Our communities have to have an integrated community policies and procedures to be prepared. Like when you call 911, what happens when somebody is suicidal? Who's responding? How do they respond? What does that look like? What does the referral system look like? Schools have become the de facto mental health providers for most of the children in the United States. So really looking at some policies, programming, and funding to reflect that reality. That's where they're often most earliest identified. Focus on skills building, resiliency building, and wellness. And then finally make sure that all of the professional caregivers, staff, and administration are supported in their self-care. Wow, I did it.
You did it. That was fabulous. That was a lot of information, and I didn't get lost once. I was right
there. Okay, good.
Thank you so much, Dr. Marilyn Zimmerman. You are awesome. I hope everybody was able to get as much info out of this presentation as I know I did. So Shannon put down in the chat box here, if you have questions, please feel free to load them on into the chat box at the bottom. We have about, 8 minutes left, and this is all for discussion. So let's take use of this time to ask Dr. Zimmerman some questions and get some good feedback. So if you have questions, please gear them into the chat box.
Thanks, June Ellisted. Oh, thank you.
All right, so Anna has asked, how has the effort been sustained? That's a great question, Anna, thank you.
So the tribe has remained in partnership with us, and I think we've had 3 rounds of Garrett Lee Smith funding. We have been the fiscal manager of it through the University of Montana at the request of the tribe. And so now, because of it, finally, there's a lot of local buy-in and a lot of local support. So for the tribe to now be on their own and sustain this work on their own, some of the programs or some of the ways of supporting kids is thinking about the development of a language revitalization program that's supporting culture camps, that supports resilience, the health promotions and disease prevention program is sustaining a psychiatric nurse practitioner. They've gone through a couple of them already, but trying to sustain that so that many of the students can get mental health or behavioral health medications and have it done well. Let's see, HBDP has taken on a lot of it, but it's really the grassroots is, and unfortunately, we lost the director to COVID this past week, and it's been a very difficult time for us and a time for the tribe, but they are able to sustain and just do the work. I think they are now also at the place where they can be the applicant themselves. They don't need us. They don't need anybody on the outside to come in. But the effort has been sustained.
Great, thank you so much. Great question, Anna, and I'm so sorry to hear about your loss. That's just heartbreaking, and I know it has an impact on communities in the bigger picture. So I apologize, and I'm just thinking of you and sending virtual hugs to your community for some healing. All right, do we have any other questions? Give a few seconds here to see if there's any questions geared towards the presentation. This was a lot of fabulous information. I know that Indian country, I know a lot of grantees I specifically work with, a sort of universal plan like this is something that they're aiming for and gearing for. So I'll go ahead and ask a question until we get another one populated here. But what are some first steps or maybe pre-steps to getting something like this going in other communities? What would you kind of suggest for people to kind of get their ducks in a row to get something like this going?
Well, again, that community collaboration is everything. Somebody has to be the champion. And for this community, it was the tribal health director. And he just did a fabulous job of bringing everybody together. He had maintained good relationships with non-tribal programs, with county programs, with county and state law enforcement, all of that. And so he was quite the catalyst and quite the person who could bring people together. So, because I think we always want to try to remember that suicide prevention is a community, needs to be responded as a community, because too often we blame the school or we blame law enforcement, we blame Indian Health Service, and that it's unfair to think that one system should be responsible for that kind of effort. So that's first. Then just getting those key players that are invested and providing them with really good information. So going on now and looking at webinars that talk about suicide prevention and what it looks like. There's the SAMHSA manual, Live to See the Great Day That Dawns, that can be used for community development. Use that as your go-to manual. I mean, seriously, it's still relevant all these years later. It's very good. And don't be dissuaded by the length of time it takes. You know, with Ms. Whiting-Sorrell asking the question, how is it sustained? It's been difficult to get things off the ground, but those things that did get off the ground, like the idea of, again, identifying kids in the school system, how do we do that? We don't necessarily want maybe a teacher, or maybe suddenly all of a sudden the school where it happened, they lost all their counselors, they've only got 2, and they're more career counselors than actual therapeutic counselors. So the tribe took on the role and has a good relationship with all of the schools across the reservation. And they took on the responsibility of housing the Suicide Prevention Project in their department. And they took on the responsibility of hiring the medical staff and the counseling staff, because to be able to go into the schools to provide support to the kids, and also reducing that stigma, so that when the children were in, getting their weight or getting an aspirin or whatever it is, they could also be identified as having some risk to suicide or other mental health or behavioral health issues. So it really is a community conversation. Oh, thanks, Anna.
I see a question here. Sorry about that. In the Q&A, and it looks like Brandon Burke has asked, how would you attack a tribal reservation that has 7 communities and stretches over 100 miles, and each community is different?
Right. Yeah, I'm from a large land-based tribe too, and it's 86 miles wide by probably 56 miles deep, and we have that many communities. And you start where there's the buy-in. You start in one community and you make small steps. And I think you go for some low-hanging fruit and make sure that so you have some early successes to keep the momentum. And then I feel like then the champions can go from community to community and build that up.
Great question. I think a lot of tribal communities might experience that same thing, and I really appreciate you answering and speaking to this and giving us some insight, your very specific insight. So thank you very much. I know we're wrapping up on time here, so if there's any last minute questions, or Dr. Zimmerman, if you'd like to add in anything before we close up, that would be fabulous.
No, but thank you all for joining. It's just ongoing work, and it really is about prevention, about anything, whether it's suicide or substance use or whatever, is really about building resilience, addressing trauma and building resilience. It's my mantra, it's my war cry, it's the bulk of my work. So just look at resilience, building resilience in children. Thank you.
Thank you so much. We appreciate you, appreciate your time, and appreciate all of you participants for joining us today. My dog, Mamba, says that was a great presentation as well. So thank you all so much.